All right, welcome everybody to the December uh, MIDAS webinar, our last of the year. Really appreciate your coming. I think we've got up to a reasonable number of folks here, so I think we should just get started and give our speakers all the time that they need. I'm encouraging people to stay around a little bit after the formal part of the presentation is over because we're going to have a special brief presentation by folks from the CDC talking about some fellowship opportunities. But for now, let's get started with the main part of this here. I want to introduce Benjamin Singer, who is an infectious disease modeler based at UC Berkeley. Dr. Singer received his doctorate from Oxford for a thesis titled Metapopulation Models for Pandemic Risk and Control. And he is at Berkeley. He's worked on a range of projects in the control of neglected tropical diseases, antimicrobial resistance, sexually transmitted infections, and respiratory viruses. And so today, he's going to give us a talk about the reemergence of viruses that were repressed during the pandemic. So with that, I'll hand it off. Dr. Singer, floor is yours. Looking forward to your talk.
Thanks for the opportunity to talk about this work, looking at data from before and after the COVID-19 pandemic, or the acute phase of the COVID-19 pandemic, to really try to learn a bit more about how endemic viruses spread. Um, so thanks. That was a good introduction. This is just a summary slide, again, summarizing who I am. Did my doctorate in Oxford, came to the Bay Area, started at UCSF with Nathan Lowe, looking at schistosomiasis, and moved with him to Stanford. And now I'm working with Joe Lunard at Berkeley. And at Berkeley, we're part of this Center for Outbreak Analytics InsightNet network. So for those of you who haven't heard of it, that's a big sort of network of different sort of network of networks, different centers across the country trying to integrate infectious disease modeling and analytics with public health sort of practice. So the center that we're attached to is the center managed by Kaiser Permanente with an innovator grant. Um, Okay, so I'll start setting up the problem that we want to solve. So endemic viruses have can often cause annual or biennial outbreaks that look pretty similar over the course of several years. And so it can be pretty hard to tell what are the dynamic drivers of these outbreak patterns. So, okay, let's focus on what causes an outbreak to start and what causes it to end. One kind of common answer is that that's due to seasonal forcing. So things like temperature and humidity changing how viruses transmit, or human behavior changing over the course of the year. And, this pushes up the transmission coefficient enough that an outbreak starts. And then let's say it gets a bit warmer, the virus doesn't transmit as easily, and the outbreak ends. But there's alternate explanations we could have for why an outbreak ends. So, for instance, maybe enough people get the disease and acquire enough immunity that this pushes the R naught below 1, and that's why the outbreak ends. And then perhaps the outbreak begins again because of seasonal forcing, or maybe because new people are born who don't have immunity. Or maybe it's not new people being born, maybe it's people who previously had immunity experiencing waning of that immunity. And so you can see there's actually a lot of different possible ways we can think about the dynamics here, and lots of competing explanations for the patterns we see. And this gets even more complicated when we start to think about age structure. So this is a really important part of the epidemiology of seasonal viruses, and a lot of other things. And this is just, which age groups are most affected by the virus. So here's an example of RSV and influenza. So RSV tends to cause the most disease proportionately in very young children. So here, the infants under 3 months of age are the most affected group proportional to their size. But for flu, older people tend to be much more affected. And again, there's multiple ways that we could explain this. So um, maybe as you get older, you get infected, you acquire immunity, and that's why you're not as affected. Or maybe it's due to the different patterns of contacts that people of different ages have. And then also, we believe that there's a sort of underlying biological age-dependent risk of disease. And again, so there's all these different factors that might explain the patterns we see. And when we see the same patterns over and over again, it is really hard to get models that can distinguish between these different possible explanations. What you would need to actually get at the dynamics, the dynamic drivers, is some sort of perturbation to the system, some sort of unusual dynamic event that lets you see how the system responds when things change. And as you may be aware, such a perturbation did in fact recently occur. And by the way, I want to make sure that people feel free to raise their hands in Zoom at any point if they have questions throughout the presentation. I'm just really happy to answer questions as we go. Anyway, so this data is from Kaiser Permanente, the Kaiser Permanente kind of hospital system. And it's really useful. They have a really well integrated data management system, so we can really get at a lot of these interesting questions. So these are the test positive acute respiratory infection cases showing up in hospitals every week. And we're using hospitalization data to try to control for some healthcare seeking behaviors that might change over the course of the pandemic. Um, what we can see is that the reemergence behaviors of these different viruses really vary after the period of suppression during COVID, which occurred because people were contacting each other less because they didn't want to spread COVID-19. Um, so in particular for RSV, you can see there's actually a very early, very large reemergence outbreak, and it happens early relative to the normal seasonal pattern. Whereas for something like influenza B, it actually still hasn't reemerged according to the working definition of reemergence that I'm using, which is a infectious disease season. So that runs from October to the next October. A season in which you see at least 50% of the hospitalized cases that you saw in the median season before COVID-19 emerged. So this is a really great source of data, and what's more, it has age structure. So here I'm just summing cases over seasons, and this kind of illustrates a bit more clearly how the reemergence patterns worked and how the age structure changes over time or between pathogens. So just broadly, there's a bit of a divide between the two types of flu and the other pathogens. So the two types of flu tend to affect adults and especially older adults, whereas the other pathogens have a lot more cases in young children. And looking at that age structure kind of at a more abstracted way, we can look at the kind of profiles of relative incidence between age groups before before the pandemic and in the reemergence events. And it's really interesting to try to think a bit about why these might change. So, metapneumovirus is a good example here. Uh, in both before and after suppression during COVID, the most affected group is these infants 3 to 11 months of age. But in the reemergence outbreak, some of that weight shifts into this older 1 to 4 year old age group. And a possible explanation of this is that children who would have been infected when they were 3 to 11 months old weren't because of reduced contact during the acute phases of the pandemic, um, and then experienced those infections later because they hadn't built up immunity. I think this is a pretty good explanation for what we see with metapneumovirus, but this doesn't explain everything. It doesn't explain why metapneumovirus and adenovirus look different, why we see a much smaller effect of this kind for RSV, and why influenza B and parainfluenza 3 show completely different patterns. So this leads to the objectives of the study. So what we wanted to do was to use differences in post-COVID-19 reemergence epidemiology to resolve parameter identification problems. And once we got a better handle on these dynamic parameters, we want to understand how they drive differences in viral epidemiology. So, in particular, why different viruses affect different age groups. And then also, it's really interesting to think about what are the similarities among these endemic respiratory viruses of humans and what causes them to become endemic in the first place. So, to try to ask dynamical questions, we need a dynamic model. So, this is a fairly standard kind of compartmental model with susceptible and infectious classes. And then these are multiplied 3 times into 3 susceptibility classes. So the assumption is that over the course of your lifetime, when you get infected, you gain some immunity, so you're less susceptible. And then this can happen again, and then you kind of max out. Um, this last boost in immunity can wane. Um, and I assumed there was no waning from the second susceptibility compartment to the first, partially just to simplify the model, but also inspired by some serological information. Um, and then, because a lot of our questions are about age distribution, we needed to have age groups in this model. So we used 7 age groups, which were illustrated in the previous figures with people born into the initial susceptible compartment, aging up through the age groups, and then there's death out of the last age group. And then finally, on top of this model, there is a observation model, assuming that your chance of being hospitalized and tested for acute respiratory infection varies depending on your susceptibility class and your age, with flat rates. So this is a model that is fairly complex. There's quite a few compartments here. And that's needed to try to fit the data from all these different viruses. So we're using the same model structure for all the different viruses. But it's also pretty simplified compared to a bunch of other things you might want to throw in there. And that's just so that we can A, properly calibrate it, but B, really understand some of the basic dynamical questions that we're asking. So that's the simple version. There's also a bunch of data that we put in to try to um, make this a bit more realistic. So the birth rate is informed by real data. The contact matrix between people in different age groups is informed again by real data. Um, then we wanted to capture the changes in people's contact rates that occurred over the COVID-19 pandemic. That's informed partially by arrivals at LA airport. So all this data, by the way, is from Southern California. Um, and and that's informing a sort of flat import rate that we have in the model. And then we also used a stepwise contact model, and we fit the timings and size of these troughs to the data. And then finally, one thing we wanted to do is, so we imagine that if California was not experiencing a lot of contact with the rest of the US, it might actually have quite different seasonal patterns of different respiratory viruses. So We did think that we needed to include some data based on what we think is happening in the rest of the US. But the data we have on the rest of the US is test positivity, which is a bit of a different kind of data from what we're using. And we also wanted to avoid like circularity, obviously, in our model fitting. So we tackled that with two approaches. First, we excluded data on um, test positivity actually in California. And then we also just fixed the number of cases being imported from other parts of the US to a very low number, perhaps enough to help model the sort of reintroduction or, yeah, sort of the reintroduction of pathogens after suppression or between seasons, but not enough to actually drive the dynamical patterns that we see. So this is, yeah, this is part of those imports that are kind of multiplied by the uh, proxy that we have for the amount of travel going on. And we have these for all the different pathogens. So, okay, we fixed a bunch of the parameters with data, or other parameters are more to do with the lockdowns or observations. You know, there's a lot of sort of superstructure of this model to try to actually get it to fit the data. But what we are fundamentally interested in are six key free dynamical parameters. So in this model, those are the sort of raw infection power. So that's the basic reproduction number. The immunity that people get after first infection. So that's the difference in susceptibility between S1 and S2. The immunity that people get after subsequent infections. Um, and the rate at which that immunity wanes. And then just the amplitude and phase of seasonal forcing. And as we try to think about what these, how these parameters drive the epidemiological outcomes that we see, one thing we might be tempted to do is just take the space of different parameter values, simulate a bunch of hypothetical viruses, and see what their outcomes are. Um, the problem with this approach is that this parameter space is full of viruses that are completely unrealistic or completely uninteresting. So, viruses that infect everybody multiple times every year, or viruses that don't spread at all. So what we need is some sort of guide to this treacherous parameter space. And that's where the fits to actual data come in. They help us know, okay, what parts of this parameter space actually correspond to realistic viruses of humans. And once we have that, then we can define a subspace where we can use this simulation approach to understand the ways that these different dynamical parameters drive epidemiological outcomes. So to calibrate the model, the main approach I used was differential evolution. So this is a sort of non-parametric evolutionary algorithm to do a global search of the parameter space and to find a point that maximizes the likelihood of the data that we see. And then to try to generate uncertainty intervals around those fits, I've been using, just MCMC. For the fits I'm going to show you today, they're quite fresh, and they don't have those uncertainty intervals generated yet. So I'm afraid you won't get to see those. You'll have to wait for the publication. Um, so this is the differential evolution fit to the data. So in blue, there's the model fits, and in the red, there's the data. And we're really pleased with these fits. You don't know how how many times it took to actually get us to work. Um, and you'll notice that even with that, we don't really get a lot of the year-on-year variation in outbreak size, and that's pretty much to be expected. We think that that is driven a lot by changes in strain dynamics or stochastic events. And that's not really what we're interested in, and it's not included in our model. But what we do manage to fit, and what we're really excited about, is the timing and relative size and other characteristics of those re-emergence outbreaks. And that's really the part of this data that we thought could help us understand a lot more about the dynamics of these pathogens. And so that's what we're really pleased to be able to capture in our models. So this gives us a bunch of points in parameter space corresponding to the different pathogens. And it lets us think a bit about epidemiological outcomes, like, time to reemergence here. But on its own, it doesn't give us those dynamical lessons that we want. So, like I said before, we use these points to generate a restricted parameter space. And for those of you who know a little bit of geometry, these are two-dimensional projections of the surface of a five-dimensional simplex embedded in the sort of larger parameter space. Um, so once we've actually restricted the parameter space well enough, we can get these surfaces and start thinking about what the roles of these different parameters are. Um, but a lot of these surfaces are somewhat disappointing. They don't have a great or very interesting structure, and the structure that you do see, these kind of streaks, seems to reflect a lot more the way that we've constructed the restricted parameter space rather than anything really interesting about the parameters themselves. Um, but I think this is just because these are the wrong angles on the problem. And actually, there is one parameter combination that gives us a really nice um, geometric structure. So those two parameters are the basic reproduction number, so just that transmission force, and the immunity that people get on their first infection. So that's the immunity that tends to last. And this structures the space in such a way that we get a really strong pattern that helps explain some of the epidemiological outcomes that we see. So just looking at the time that it takes until the reemergence of the pathogen, um, there are some intuitive patterns here, right? So RSV, we think, has a really high R naught, and pathogens with a really high R naught just they're really transmissible, so they come back and they come back in a big way really early after the pandemic. Then if we look at a more moderate reproduction number with high immunity from first infection, so that's kind of like adenovirus, what we see is a big reemergence event, but more in line with the normal season. So if RSV and similar pathogens come back really early relative to their usual seasons, whereas something like adenovirus comes back more in line with the normal season. Then, as immunity goes down from there, you actually start seeing a small early outbreak. So people don't have that immunity that prevents that from happening. But that small outbreak doesn't trigger our definition of reemergence, and it actually gives people enough immunity that it delays that true reemergence event until later. Then, as immunity goes down, that initial outbreak gets bigger, and so that ends up being the actual reemergence event. And then finally, down in the corner with the low reproduction numbers, we have things that work like flu, which just take a while to come back because they're simply not that transmissible. And then also we get a lot of insight into these age structure differences before and after the suppression during COVID. So, for instance, we see RSV just has this, huge infectious pressure in young kids because it has that really high basic reproduction number. And so you don't see a huge change in the age distribution before and after suppression. But for something like metapneumovirus with a more moderate basic reproduction number, we can see that these two parameters again seem to explain the pattern that we see in terms of that, immune dynamics pushing that ratio of those 3 to 11-month-year-olds and those 1 to 4-year-olds into a different pattern. And just to show this is the size, the relative size of the rebound. And again, you get this effect where, oh, sorry, the axes are not labeled correctly here. But these very high R naught pushes this size up. But then also if you have this moderate R naught, but this really high immunity on first infection, you're going to get a huge kind of resurgence outbreak because of this kind of relative lack of immunity compared to the pre-pandemic times. But the objectives of this study weren't just to explain the re-emergence behaviors, but to try to actually get at what drives the behaviors of these pathogens in ordinary outbreaks. Um, And this is where, the dynamical insights from just kind of focusing on this restricted parameter space and looking at this kind of angle with these two parameters can really start to bear fruit. So I mentioned earlier there's this divide between the 6 pathogens that we have data on, between the influenzas, which tend to affect older people, and the other pathogens, which tend to cause more disease in young children. And what we see is that these two parameters actually explain a lot of this divide as well. So here I'm using as a proxy for age structure the relative force of infection experienced by infants under 3 months of age. And we can see that if you have this high basic reproduction number, that leads to those infants experiencing a very strong force of infection. But as well, if you have this large immunity after your first infection, then again, relatively, those young kids are going to experience a lot more of the force of infection. So I've been focusing so far on the differences between these pathogens, but you may have noticed a similarity. It's just that they all exist kind of all along this line, this diagonal line in the parameter space. And I think this can help us get at a somewhat more fundamental question about how endemic viruses persist in the first place. So if we take the x-axis to a log scale, and we just draw a simple line through our points, we can think about this relationship actually between the basic reproduction number and the immunity from first infection. And I think this is quite intuitive. So if a pathogen causes a huge amount of lasting immunity on its first infection, then it's going to need a much higher basic reproduction number to persist in the population. Whereas if it causes relatively little immunity, then it can keep persisting in the population even with a lower basic reproduction number. And we actually see, and finally, what we wanted to do is to take this relationship that we're kind of hypothesizing based on our data, and see if it works with other people's findings. And using a few parameter estimates from the literature for viruses that weren't in our data set, we see that this relationship actually seems to hold pretty well, out of sample, as it were. So to conclude, the perturbation from the COVID-19 pandemic has been a really sort of fascinating thing to happen in terms of data, and it's allowed us to identify drivers of viral dynamics that would be really hard to tease out without those reemergence events. And what we found was that the basic reproduction number and the acquired immunity on first infection explain a lot of the differences and similarities that we see in viral dynamics. And our hope for the future is that understanding this relationship between seasonal and perturbed dynamics for respiratory infections will help us respond appropriately to future reemerging diseases. Um, and yeah, just quickly to go over what our next steps are with this project. Um, I think I mentioned that there's some serological data that we've been looking at to support our modeling structure. As some more of that serological data comes through from Kaiser, we want to really use that in a more stringent way to drive some of how we think about acquired immunity. There's also another element that may drive some of the patterns that we see that is not included in this model, which is interactions between viruses. And this is a simple analysis of the infection data that we have to see whether co-infections are occurring at a lower rate than you might expect based on a few other covariates. And we do seem to find some evidence of viral interactions in this data set. So that's something we want to incorporate in the future. And then finally, we're interested in using data from other countries, other health systems, in particular, South Korea. I'm wrapping up pretty early here, so I'm really happy to take questions. But I'll just quickly say thanks to the people who've made this work possible, especially at Kaiser. Sarah, Venice, and Bantry have been really helpful getting this amazing data set together and with their inputs into the modeling and so on. And Joe Lunard, my supervisor, has of course made this work possible, as has the CDC and CCOR. Thanks everyone for listening.
We do have some questions in the
Great, thank you.
Q&A.
Yep. Yeah, let me take these questions here because the first one here, I'll read it out and I want would like to hear your thoughts, but then I've got some follow on here. But the question being, could the changes that you saw in some of these behaviors be confounded because, with RSV in particular, you saw the introduction of the vaccine coming in, and how does that influence your results, if at all?
Yeah, so the vaccine came in 2024. So first of all, that's kind of after the re-emergence event, which is what we think has the most sort of interesting information. But I think for RSV, you can see that, again, like I say, we're not perfect at getting the size of the peaks, but I think one reason that this peak is lower than what we predict is because in the 24, 25 or I guess, yeah, 24-25 season, we actually saw the real start of introduction of this vaccine. And so that's probably driving part of why this outbreak is lower than predicted by our model. So, and actually we've just managed to get data on vaccination prevalence in our sample through. So that will be included in the model, but obviously it's a very good thing to include in the model, but it's not driving the reemergence event, obviously, because it started really being rolled out after that.
Yeah, I'll hold on to my follow-up question here. We got a few more in the Q&A, but one question here asks, how are you considering the immense variation in immune status for people in the same age group?
Yeah, I mean, it's a compartmental model. So we're assuming that you can capture this as a sort of average, which, to be fair, is pretty successful a lot of the time. I'm sure there's all kinds of investigations that you need to, capture those variations a bit more, but for compartmental models, it tends to be pretty successful to treat it as a sort of average.
And a related question there, how do different modes of transmission affect this analysis, e.g. aerosol transmission?
Yeah, I mean, I think probably the main effects of those, I mean, are first on just the R naught, um, and also on how they respond to those to contact changes um, during the COVID-19 pandemic. So we do allow different pathogens to experience a different change in their transmission during the pandemic.
Okay, there's another question here, which I think you sort of touched on, but it's a two-parter here. One, just wondering why your model fit didn't capture some of the peaks in the data. Is it the type of seasonality function you used? And then two, are you thinking of using wastewater data as part of your next steps?
So there's a lot of reasons that our model could fail to fit some things. Um, I'm not sure exactly what you mean by not capturing some peaks, as in, but like I said, I think that there's a lot of strain dynamics going on here that we're not capturing, um, and a lot of stochastic dynamics that we're not capturing, clearly. Um, but I think we do manage to capture most of the notable or relevant peaks. Um, in terms of wastewater, I think that is such a different kind of data from this. Like, this is really clean data, which is why I've been so excited to work with it. It's very resilient to changes in healthcare seeking behavior or in different medical practice. And we have a lot of control or a lot of insight into all those factors that might change. Wastewater data is the complete opposite. You're really at the whim of a bunch of stuff that is outside of your control or outside of your data set. So, I think wastewater work is really incredible and obviously incredibly valuable for disease surveillance. But when we're trying to get this really tight data to get at modeling questions that are really hard to approach in other ways, I think wastewater data is I don't want to say it can't be used for this, but it would be a completely different challenge, I would say. Yeah.
So here's another question. I'm interested to see your viral interaction work. I wonder if your data is longitudinal such that you can observe which viruses come first for each individual. Often the case is that we only observe co-detection or not.
No, yeah, we do have actually data on. I mean, obviously, ideally you want like a sort of longitudinal cohort data where you're testing everybody over and over again, which we don't have, but we do have identifiers, kind of pseudonyms for each of the individuals in the data set. So we might be able to capture some of those time-dependent effects potentially. I mean, you'd have to rely quite a lot on chance to get you that, but I haven't really looked at that the order of infections. So it's a really good question. Something that yeah, I should investigate a bit further.
Okay, so another question here. Do you think that the changes in flu B could be affected by the extinction of the Yamagata lineage so that the post-pandemic is only Victoria? For context, Yamagata had a bimodal age distribution infecting older adults, where Victoria's was unimodal, mostly children.
Gosh, yeah, I didn't know that about the different strains, which I obviously should have. Um, do we see that in? Yeah, it doesn't really show up in this figure, does it? So it's quite interesting. Yeah, that's a really like I say, we don't capture strain dynamics in this model, so that's a bit sort of out of the wheelhouse. Um, and what we do manage to capture is that long delay until the reemergence, and that's kind of fundamentally what we're interested in here. But the difference in age structure between those two strains, I wasn't super aware of, and that's something that I should think a bit more about when interpreting this kind of thing.
Do we have any other questions? I mean, I'll throw something out here, given it I haven't heard from anybody else. But one of the things that occurs to me here is that you're using sort of the intervention of the pandemic as this sort of critical moment here to see how things differ and change and what happens afterwards. And what I'm wondering about is, how do we really even understand that at some deeper level? And the fact that your models seem to fit pretty well, that's nice to see. right? And your curves look really good, but is it really just the case that the pandemic was this interruption and everything is as it was beforehand, or have certain dynamics changed in really particular ways or more general ways that might have longer lasting effects that we're not even really identifying yet? I'll just give one example that clearly for anybody who works in any sort of office environment knows that the social contacts at work are not what they were in 2019. And there may be reason, and I'm not familiar with this data myself, but there may be reason to believe that we're going to see some long-lasting changes in vaccination patterns. And so I guess is the provocative way to putting it, which is going to be very hard for you to answer because it's an ill-formed question, is just to say, is the pandemic an interruption, or is it a fundamental shift in underlying phenomena?
So I think like clearly, yes, there's a version of that question which I simply couldn't answer. But I think there's the examples that you brought up are things that we can include in the model. So um, the contact model, it's pretty subtle in this figure, but we do allow for an ongoing effect where contact rates after, 2023 or so are lastingly different from what they were before the pandemic. So that is something, a possibility we do include in our model. And then in terms of vaccination, we actually do have data on vaccination rates in the population we're looking at. So the Kaiser Permanente Southern California insured population, we know their vaccination rates, and so we can capture some of that in our model. So those kinds of things, we do actually, and also changes in airport use, travel. So a lot of those long-lasting effects we actually can capture in the model, which is quite nice. Um, in terms of, again, strain dynamics, right? The disruption to strain dynamics is something we don't capture and is also fascinating and is, let's say, very worthy of further study.
Got it. Okay. And there was a question here, which I think you just answered. Does the model account for vaccination rates for flu and RSV? And it seems clearly you're saying the answer is yes, you were accounting for that.
The answer is yes for flu at the moment and soon for RSV.
Mhm. Got it. Interesting.
I have one question.
Go ahead, Praveen.
Yeah. Hi, Benjamin. It's nice presentation. When you were calibrating to the infections, number of infections, does that include asymptomatic infections as well, or is it the diagnosed part?
So this is all people who show up are
Sure.
admitted to hospital for an acute respiratory infection specifically. So this is not looking at tests that people get. If you show up to the hospital with a broken arm and they decide to give you a flu test, that's not showing up in this data set. And that's specifically because we wanted to filter out changes in healthcare seeking behavior over the pandemic. So specifically looking at people who show up in hospital and get tested because of
Okay.
their respiratory infection.
Got it. Thanks.
Okay. There's one other question in the Q&A. Question being, do you have any plans to do forecasting in the future, or are you sticking to retrospective models?
There's some vague plans to see if these can be used for forecasting, but like I said, they're actually the point of these models was never to get the size of the outbreaks, or not to get their absolute size, to get their relative size. So I think there's a lot of the interesting questions that you want to answer with forecasting, these models aren't very good for. I think that what they can do though is that they can inform parameters that can go into forecasting models. So I think that is definitely a spin-off from this project, but not a direct application from it, if that makes sense.
Sure. Definitely makes sense. Okay, any other questions?
But I think it could be interesting just to see what it predicts for the next season and see how how close the truth is to what this model predicts. That's always a fun exercise.
Mhm, mhm. Well, if you did as well as on the timing, that would be great, even if the magnitude weren't quite so spot on.
Yeah.
Um, okay. Any further questions? Last call. All right. Well, I'd like to thank Dr. Singer for a nice talk once again. And thank everybody for coming, but I want you to stick around because now we're going to try to hand some things over to Carlo De Villapayan and Adam Skelton, who are going to talk a little bit about fellowship opportunities at the CDC. So Carlo, Adam, the floor is yours. Please take it away.
Thank you. So I think Adam is signaling me to get started. I don't know if you want to say anything first, Adam? No? Okay. Then let me share my screen. And please let me know
Yeah,
if you see my presentation.
looks great. Please go ahead.
Very good. So we are here from the CDC. I'm sorry, my throat is not doing great, but we're here from the CDC, specifically from a fellowship that has visited this group several times before, which is the P Fellowship. And this fellowship is actually a nice way into the CDC for those graduate students with a PhD. So who who is this fellowship looking for? Qualified applicants will have a PhD in one of the areas that we're trying to hire. Basically, we hire into two main areas. One of them is economics and policy, and the other one is analytics and modeling. Of course, in MIDAS, we expect fellows to lean towards the second group, analytics and modeling, although we do not discourage anyone with an economics background or policy to apply. We have both tracks, and we're currently hiring for both. It is a 2-year postdoctoral fellowship, and it's directly working with different groups at CDC, which we call the host sites. So one of these host sites, and we have maybe around 15 host sites at the CDC looking for fellows. And what we expect to see are these host sites proposing projects and hiring a certain number of fellows this coming year. Let me just say that last year we were also hiring, and because of all the changes that were there with the federal government, we ended up not hiring fellows last year. But this year we feel very positive that we may be able to hire some fellows. The analytics and modeling track, then we want people with already an analytics and modeling background, a PhD in analytical or modeling areas, mathematics, and things like that, biology, science, engineering. And what we want is to further develop the characteristics of these particular individuals into applying those capacities that they have into the public health realm of modeling, disease modeling and vaccination effects and disease, natural history, and things like that. We have, for example, in the past, have fellows working on COVID-19. We have a ton of fellows working on COVID-19. Of course, many of our fellows support, or all of our fellows support our decision making. And we have several initiatives that have been funded and led by CDC that will hire these fellows. And of course, our fellows become very valuable to these teams. Here are a few numbers of previous years of fellows. For example, in 2024, we had 16 fellows, 6 traditional fellows, and 10 modeling fellows. And as I said, we expect to have some of these numbers around these numbers this year. In 2023, of course, we had some disease going on, and many teams were able to hire. So they hired a total of 22 fellows, 7 traditional, and the traditional ones we're calling the economics and policy fellows, and then 15 modeling fellows. More than 250 fellows have completed the 2-year fellowship since 1995. And of those, 70 alumni are currently employed or were employed at CDC in 2025, sorry. And the last classes, we have been successful in retaining like half of the fellows from the class, which is very positive for us. What is the background of our fellows? Around half of them have been people studying economics, and basically more because remember the traditional fellowship was based strongly on economics. But now in recent years, we have been hiring more health services, EP researchers, engineers, operations research, mathematicians, biologists, ecologists, and so on. Our fellows are very, very productive, by the way. And we have a lot of publications. Just in 2024, we had 179 publications by alumni and fellows. 1/3 approximately of these were written by modelers. Of course, our fellows feel the fellowship has contributed strongly to their development professionally. Many of those who stay at CDC, of course, the PE fellowship is a great entry point for them. What is asked from the fellows is that they write a couple of papers in the 2 years they have here. So 2 papers in total for 2 years. And also delivering professional presentations at conferences, for example, and delivering methods-based trainings as well. A few examples of opportunities for service in the PE Fellowship are deployments. We have had fellows participating in disease deployments. And a deployment, we call it when someone was doing a certain project and then they have to interrupt that project to go and work specifically on a certain disease that is happening or on a certain response that the CDC is participating on. And here are a few examples. And we have other opportunities for service. One of them I like a lot is this last one, methods-based workshops and professional seminars. We have so many good people that actually our fellows direct those and deliver those. We have a very interesting pay for a postdoctoral position. I am sorry to others who may have postdoctoral positions that may not be able to pay so well, but this is, of course, very positive for our fellows. By the way, our fellows not only get a very nice salary, but they get all the employee benefits of being a full-time employee at CDC. A very nice health insurance. If someone gets a good health insurance, is CDC employees, of course. Annual leave, sick leave, federal holidays, retirement plans, and visa sponsorships. We have our own sessions. As I said, we try to have the fellows learn, or at least kind of level up their abilities in modeling, in economic analysis, and in application of statistical models as well. So we see that the peers are trained in a number of these areas. Some of our fellows are now enjoying very nice positions somewhere else. But of course, what we want you to have to apply is a PhD in epidemiology or ecology, biology, operations research, industrial engineering, math, and so on, qualitative disciplines. Non-citizens must be eligible for the OPT STEM if they are on an F1 visa currently, because there's an OPT STEM extension that may apply to your visa. So please check if your institution offers this STEM extension that would be very positive for your application. And you have to be willing to move to Atlanta, especially lately. The requirements are that students will move or fellows will move to either Atlanta or to wherever their team is located so that they can be working in person with them. Most of the positions are in Atlanta, but some of them are not. So you would have to see about that. How to apply. Now we have an application open until January the 9th. So please, if you're eligible and you would like to participate and you have not applied yet, you have until January 9 to apply. Please go to this website, www.cdc.gov/PEF, and you will see all this information there, and the application as well. And just in general planning, the fellowship starts in August 10, and we will require for you to complete your PhD requirements by something like July 19 or something like that, so mid-July. We expect you to be done with all of your PhD program and presentations and whatever you need to do. You need to defend your dissertation by then, so that you can be considered to get started with this generation of fellows. And that's it. Please let me know if you have any questions.
Yeah, we have time for a few questions if anybody wants to throw them out, and you can put them in the chat or unmute. I really encourage people to consider these fellowships. It's a great opportunity and great chance to work with a very strong group of people. And my impression is that folks get into the CDC world and they really find it a challenging and interesting place to be. I'm curious, just as from the outside, and obviously not as an applicant, but are you seeing opportunities to bridge the gaps between these two worlds of the modeling on the one hand and the economics and policy on the other hand?
Well, what we see is that one needs the other to make sense of the problems we deal with. So usually what we see at CDC is that these two groups are often merged into an economics and modeling team, just because one of them works on the effectiveness, the economic analysis, while the others work on understanding the problem more deeply in the modeling side. And that's why actually we ask our modelers to learn some more economics or econometrics, right? And at the same time, we ask the economic people to understand what the models are about. I think there's a question by Kara. It says, I wanted to check if the recommendation letters should be formatted as a letter. I heard that for EIS in the past, it was actually a series of questions. Want to make sure recommendations are in the correct format. Yes, actually we do the same as EIS, which is ask a bunch of questions and have your professors go into the site and answer those for you. If any of your professors would have a problem with that, let us know. We may have options, but in general, that's the way we capture them. We just have them go into a website very similar to the one you go to apply to, and in that they can write about you and say who you are and how good your math and analytics and modeling strengths are, and how good they think you will be for our program.
Well, I wanted to just say, yeah, contrary to popular belief, the CDC is open for business. We are recruiting fellows in the class of 2026. We have lots of interesting post-site assignments in everywhere, everything from influenza to stroke and heart disease, to the World Trade Center health program, lots of opportunities for interesting work. Yeah, the letter of recommendation form in FMS which is our software, is a standard form, but tell your referees that they can just copy and paste their letter of recommendation in the comments section of that as well. So, a lot of people prefer a lot of people prefer a traditional letter of recommendation. I do as well. I don't particularly like those standardized forms, but tell your recommender that they can just, either email us one or attach it to the to that segment of the application.
Okay, there is another question here about basically looking for what's your acceptance rate in the past, and then also how is publication perceived during evaluation.
Yeah.
Because sometimes PhD students get their first authored publication after they graduate.
Mhm. So traditionally, the fellowship has been super popular. A lot of applicants to the fellowship, and at this point, we've gotten about 250 people who have started applications for it. That being said, we've only had 30 that have submitted their applications, and we've got a month to go. So, with the host site assignments and with the general perception, I think that I think that the it's always going to be competitive, but it's going to be, I think the numbers are in your favor this year in terms of getting looks. I did want to say something about visas. A lot of our applicants are non-U.S. citizens. And again, the preferred visa for folks coming in would be something like an OPT STEM that extends the F1 visa. We cannot host H1Bs, but we may be able to host J1 visas, especially ones that are currently sponsored by your university, if you're currently in a postdoc or something like that. And very likely TN visas for Canadian or Mexican citizens. What was the second question, Harry? Oh, publications. Yes, publications are required, and they're generally pretty easy to as a byproduct of the work at CDC. Clearance has been a little bit rough recently, and that's just something that we deal with. I like to say to folks, if you can work at CDC, you can work anywhere. This day and age, that probably goes double, but you're going to get some great experience, work with some real professionals, and on some data that you wouldn't have access to anywhere else.
I think, to be clear, the question was on any requirements for publications in the evaluation process for who
you
you
mean
bring in.
coming in? No,
Yeah.
No, we understand your publications are probably coming out of your dissertation. And there have been applicants who've had a couple of years of experience who have come in with 30 publications. Most people have, one or two. And most people work on, their dissertation publications after they get to CDC as well, and push some out the door.
Great. So two more questions. I'm going to throw them out to you together here. The first one being is is there any expiration date on PhDs? So can somebody who earned their PhD in 2023 still apply? And the next question is there any advantage to applying earlier?
Apply now because the deadline is January 9th. So the earlier is now. And second, 2023 is good. It's like a slope, though. I don't know what's bad. I mean, 1993, not so good. It is intended to be a postdoc. It is intended to be, for folks at the beginning of their career.
Okay, great. And one
But
more.
2023 are welcome to apply.
Okay.
Yes.
So another question here being, does the program focus on infectious diseases only, or what other diseases are they within scope?
No, again, modeling tends to focus on infectious diseases, but a lot of folks at CDC view the skills of modelers to be applicable to things like opioids and obesity and stroke and heart disease. So, it's very likely if you apply and you get selected for interviews, you'll get selected for interviews from infectious disease programs, but also maybe some chronic disease programs and injury or environmental health, something like that, who are interested in applying your skills to their work and their data.
Okay. Great. So there was a question as to whether we would share the slides. And I think if you send them along to us,
Sure,
we can make
Carlo
them
will send them.
available.
Yeah,
So-
and
I just wanted to say,
I
I just want to say,
typed
Ben,
something.
I hope Ben is still on. I really appreciated your presentation. I learned something new every time I go to one of these things. He might have dropped off already.
Yeah, he just dropped off just a little
Yeah.
bit ago. He was
Well,
on.
send it. Tell him I'm impressed.
Okay,
And
great.
Adam, I tried to share that file multiple times. It won't do it.
Oh, the Word document we sent?
Yeah, but I did put it in the MIDAS webinar, not MIDAS webinar, the MIDAS newsletter, so it's in there.
That's fine. They'll find it on various job websites that they go to as well.
Yeah, and if anybody wants to just send email to questions@midasnetwork.us, we can get you in touch with Adam and Carlo if needed. So
Yeah, and you can share it through there as well.
right.
Yeah, I have it on
Just
our
a Word
website,
document.
so I shared the link there.
Okay. Thank you so
All right.
much for this opportunity.
Okay. Thank you all. Really appreciate your time. And as I said to folks who are eligible and interested, please do consider the CDC fellowships. It's a great opportunity. That's a wrap for this year. We will see you with the January 26th MIDAS webinar. Have a great holiday season, everybody.
Happy
Happy
New
holidays.
Year.
Take care.
Bye.
Bye.
Bye.